Here we go. Well, everyone, thank you for joining us today for the October edition of Kidney Cancer Conversations. I'm very excited about today's. This was a request from our audience to bring in Dr. Sean Williamson. He's with the Cleveland Clinic, and he's here to talk with us today about understanding your pathology report. How are you today, Doctor?
Oh, very good. Thanks. Thanks very much. Thanks for having me.
Of course, we're excited to have you. So as I mentioned before I started the recording, we will have a Q&A session at the end. So if you do have any questions, feel free to type those into the chat. We'll make sure to get those questions answered before the end of the presentation today. So without further ado, everyone please welcome Dr. Williamson and take it away, sir.
Oh, thanks. Thanks again for having me for this. I think it's sort of my first opportunity to speak to kind of a non-physician group. So I hope that something that I can present today will be useful. Let's see. I'm a pathologist specializing in genitourinary pathology, which includes renal cancer. And so hopefully I can explain a little bit about what goes into the pathology report and answer any questions. Here is sort of an example of what the top section or the final diagnosis section of a pathology report might look like, at least one that I would report. And this top section can vary a little bit from institution to institution. So there may be differences in formatting or exactly how many items are listed on this kind of top diagnosis line. But usually you have the organ site, so kidney, which kidney is it, left or right, and then whether it's a radical nephrectomy, the entire kidney, or a partial nephrectomy if only part of the kidney has been removed. And I'll sort of go through line by line some of the things here that are the highlights of each item that are reported in the pathology report. So first highlighted in yellow there, it says clear cell renal cell carcinoma. So this refers to the histologic type of the tumor. And I'll talk a little bit about the histologic types in the next couple of slides. We could probably actually spend a whole lecture just on histologic types of renal cell carcinoma, but at least I thought I would briefly touch upon these. And so clear cell renal cell carcinoma is probably the best known type, which accounts for at least about 50 or 60% of adult renal cancers. And the behavior of clear cell is, I guess, potentially sometimes unpredictable. There are reports of metastases relatively late after the original tumor was diagnosed, and it can sometimes come back in unusual locations. So clear cell is sort of our best known type of renal cancer, and it's hard to totally predict how it's going to behave, although some of the things that I'll go through the rest of the presentation today will give an idea of some of the parameters that we look at for predicting whether a tumor is likely to be aggressive or not aggressive. But that makes up definitely more than half of adult renal cancers are of clear cell type. And then probably the second most common is papillary subtype, which makes up somewhere around 15% or so of renal cancers. And in general, these are thought to be relatively favorable in behavior. For some unknown reasons, sometimes patients will have multiple papillary neoplasms, especially if there is a history of chronic kidney disease. So for some reason, papillary tumors tend to be multiple, more so than other types of renal cell carcinoma, but that's probably the second most common type. Chromophobe renal cell carcinoma is kind of a funny name. This comes from two separate parts of the word: chromo meaning color and phobe meaning afraid of. So sort of like a phobia means being afraid of something. Chromophobe, the name comes from the cells being usually sort of colorless, and so it got this name, chromophobe, meaning afraid of color. But that's the probably third most common type of renal cancer, and it makes up about 5% of renal cancers. And actually, the behavior of chromophobe tends to be mostly favorable. It's not impossible for these tumors to behave in an aggressive way, but in general, they're thought to be mostly favorable unless some of the high-risk findings of higher stage that we'll talk about later are present. A tumor that I always like to mention that I think many people are not aware of is one called clear cell papillary type. And it's interesting to me that we only figured out that this was different from clear cell in about 15 or so years ago. Up until then, we were probably mostly putting these under the diagnosis of clear cell. But recently, it's been recognized that this is a different subtype of renal tumor. And actually, it has extremely favorable behavior. And so the most recent edition of the World Health Organization classification of GU tumors suggested we can call this a tumor rather than carcinoma. So it's actually not even considered malignant anymore in the current classification. It seems that these extremely rarely, if ever, behave in an aggressive way. And so with all the data accumulating over the last 10 to 15 years that this entity is very favorable, it's been sort of renamed as a tumor, highlighting that it is, an abnormal growth, but it is currently not considered malignant, as the rate of aggressive behavior is extremely low or maybe zero. I'll show a picture of that later on and maybe touch upon that briefly. But as I mentioned, this is highly favorable, and recently the name carcinoma, which is sort of our term for a cancer of an epithelial organ, has been taken away. Other than these types, other types of renal cancer are much rarer, making up just a few percent of renal tumors. One that you might be aware of is the so-called translocation associated renal cell carcinoma. These have specific genes that are involved in rearrangements where one part of the gene gets sort of hooked up with another gene, which it's not originally supposed to be connected to, and that results in an abnormal growth of the cells. And so there are a few genes involved in those translocation-associated renal cancers, but that's a rather rare subtype in the adult population. In young patients or children, translocation-associated it tends to be a higher incidence or more common, but it also does occur in adults in the normal age range for renal cancer as well. So clear cell renal cell carcinoma is probably the one that most people are familiar with. And it's named that because when you look at the cells under the microscope, like you can see here on the left, they usually look clear. So the cytoplasm, which is kind of the fluid that makes up the whole structure of the cell, it looks empty. So here you can see these dark purple dots. Those are the nuclei of the cell. The nuclei contain the instructions that tell the cell what to do, but the cytoplasm is the fluid of the rest of the that makes up the body of the cell, and you can see it's very empty here. It looks like just a bunch of white space. On the right side is just another picture of a clear cell renal cell carcinoma. You can see this red stuff is blood. They tend to be very vascular, and so you may see a lot of blood within the tumor. And actually, the vascularity of these tumors is something that may be targeted for treatment purposes. Some of the drugs that are used to treat renal cancers target the vascularity. And so if you cut off the vascular supply, it makes it more difficult for these tumors to grow. I thought I would just mention that although we refer to clear cell as having these cells with empty looking or clear cytoplasm, they aren't always 100% clear. For example, this one in the corners, you can see that the cells look clear or empty, but then in the middle of the picture, there is more of a pink color to the cells. And so although clear cell is part of the name, the color of the cells can actually vary a little bit, but usually they have this empty appearance of the cytoplasm that gives the name clear cell. Papillary renal cell carcinoma, I mentioned, is the second most common type, and usually it looks a lot bluer under the microscope, like you can see here. So on the right-hand side of the picture, the cells are really blue. On the left, there are some kind of bubbly or frothy looking cells, which are a type of cell called macrophages that are often present within papillary renal cell carcinoma. So those are kind of inflammatory cells that just happen to be in papillary renal cell carcinoma. That can be a clue to what they look like under the microscope. But on the right side here, this very dark blue appearance are the actual cancer cells of a papillary renal cell carcinoma, and it looks a lot bluer just as at your low magnification view. They look a lot more blue compared to a clear cell tumor. As I mentioned earlier, chromophobe is probably the third most common type of renal cancer, and the name comes from, again, that mean those sort of prefixes meaning fearing color. So whenever we stain the slides under the microscope, we use a series of chemicals to give the cells colors that we can look at under the microscope. And chromophobe was so named because it doesn't pick up that much color. And you can see the cells are mostly light staining. They're kind of clear, similar to a clear cell. Although some of the features that we look for as pathologists to make this diagnosis are, you can see these very crisp lines throughout the picture here. And the crisp lines are the borders between one cell and the next cell. And so with chromophobe, we often refer to them as having extremely prominent cell borders where you can tell that there's a very sharp line where one cell ends and the next cell begins. So that's just one of the features that we look for as pathologists when we're making a diagnosis of this type of renal cancer. Here's just another picture of chromophobe, and sometimes we mention that the nuclei vary a lot. So again, the nuclei are these dark purple dots, and some of them you'll notice are really small, some of them are a lot bigger, some of them are kind of wrinkly, and those are all features that we notice when we're talking about chromophobe renal cell carcinoma. And again, chromophobe is usually a very favorable type, although not necessarily always. I mentioned clear cell papillary type, which is probably a less known type, but it's actually not that rare, probably coming in at number 4, just under chromophobe as the 4th most common subtype of renal cancer. And if you look on the right here, you can see that probably these were mostly diagnosed as clear cell in the past. The cells look very clear. But maybe you can appreciate in this picture that a clue to this diagnosis is that the nuclei tend to be sort of lined up at the same height in the cell. I think it reminds me of piano keys where the nuclei, the dark dots, are kind of like the black piano keys, and the clear cytoplasm is kind of like the white piano keys. They're all at the same height. And so that can be a clue to us as pathologists to make this diagnosis. And I think this is a subtle diagnosis that may be overlooked even today, but I think it's relatively important as the behavior of these seems to be super favorable in that essentially all the patients so far who have had one of these tumors, they've had it removed, there's almost no evidence of a metastasis from one of these clear cell papillary tumors. And so again, as I mentioned, it's been renamed as tumor rather than carcinoma, since it's thought that it has minimal malignant behavior, if any. So those are some of the most common histologic subtypes, but just a few other things that come into play when we're talking about the histology is that a few of the histologies, tumor histologies, are associated with hereditary syndromes. So you may know of von Hippel-Lindau disease or VHL disease. And with that syndrome, patients have multiple clear cell renal cell carcinomas, also cysts in the kidney, also some tumors of other organs. So if you have inherited a gene, the VHL gene that has an abnormality, you're prone to develop clear cell renal cancer more easily and at a younger age than a patient who doesn't have an inherited gene abnormality. Now, that's not to say that if you have a clear cell renal cancer that you have this disease. It's actually more common that you just develop an abnormality of the gene that was not inherited. So only a small percentage of the patients inherit a copy of this gene that's abnormal from their parents. But if you do have one of these abnormal copies of the gene, it makes it a lot easier to develop one of these cancers. And if you have the disease, you have to be monitored more closely for the development of more tumors. The second one I mentioned there is the hereditary leiomyomatosis and renal cell carcinoma syndrome, also known as HLRCC. That's unfortunately kind of a big mouthful in terms of the name, but this is a syndrome where patients develop renal cancer and also benign lesions on the skin, which are known as leiomyomas, and also in the uterus. So leiomyomas can develop in the skin or in the uterus. And if patients develop many skin leiomyomas, there are these benign small bumps. Or if a patient develops uterine leiomyomas at an abnormally young age, that may be a clue to this syndrome. Now, again, uterine leiomyomas are very common. So just having uterine leiomyomas by no means means that you have this syndrome, but a patient develops uterine leiomyomas at a very young age and needs a hysterectomy at a very young age, like say in the 20s or maybe 30s, that might be a clue toward this syndrome. And unfortunately, the HLRCC syndrome, the renal cancers tend to be more aggressive in that syndrome. So as pathologists, we try our best to recognize recognize the specific histologies that are associated with that syndrome, and hopefully alert patients that they may have this syndrome at the time of a renal cancer being diagnosed. And actually, that's what I've pictured here on the right side of the screen is the histology of one of these tumors in the HLRCC syndrome. We used to refer to them as papillary renal cell carcinomas, but currently, if this is considered to be different from regular papillary renal cell carcinoma, it's considered to be sort of its own diagnosis. Another inherited syndrome associated with renal cancer is mutation of the SDH genes. So that stands for succinate dehydrogenase. And some patients that have inherited a mutation of the SDH genes can develop renal cancers. There are other tumors are also associated with that syndrome, but the SDH deficient renal cancers are kind of important to us in pathology in that they look deceptively almost like a benign tumor. They look almost like an oncocytoma, which is considered a benign renal tumor. But again, this is a clue that the patient may have an inherited syndrome. And in fact, these are malignant, even though they look deceptively benign. And so that's another one that somewhat recently for us as pathologists, we've become more astute at recognizing these and able to sort of predict and alert patients when we see a specimen, either a biopsy or a surgical specimen from a kidney cancer patient, that they may have this syndrome. So we talked about the histology, the clear cell renal cell carcinoma. That first bullet point on the diagnosis would be the tumor histology. What type of renal cancer is it? So now on the second line, I've highlighted the tumor grade, and I wanted to spend just a couple of minutes talking about what grading is. And so grading refers to kind of, we refer to it as how differentiated are the cells, or sort of how close do the cells look to normal. And in general, the more as cells progress from being normal to cancerous, the nuclei start to become more abnormal looking. And so that's not a perfect rule, but in general, the more abnormal the nuclei look, the more likely we're dealing with a cancer. And so in renal cancer, we use this grading system that's based on the nuclei. And up here in the left upper corner, you can see what we call a grade 1, where the nuclei are these little dark blue, purple dots, and they're just small, round, uniform dots. I'll skip to grade 3, which will make it easier to understand the differences between grade 2 and 3. With grade 3, you can see that within the nuclei, they're kind of purple, and then there's a big dot inside of that nucleus. So you have kind of a dot within a dot. The darker dot in the middle is called the nucleolus, and that's kind of a structure within the center of the nucleus. And so when you see this nucleolus, or this prominent dot within the nucleus, that's what we use to indicate grade 3. If you can see those easily, we call that grade 3. On the other hand, if you can only see them when you're looking at really high magnification, we call that grade 2. So it's easiest to think of grade 3 as based on how easily we can see those big dots in the nuclei. And again, this is just a transition from the cells looking more normal to cells looking less normal. And finally, grade 4, the nuclei look really abnormal with kind of irregular shapes. They're not even round anymore. They're kind of jagged with all sort of zigzagged or jagged. They're not these round circles anymore. So in general, grading is just a representation of how close to the cell nuclei look to normal. And the bigger and the more varied they get, we consider that of higher grade. So this is used as sort of a marker to try to predict how a tumor is going to behave. In general, a tumor that has the lowest grade, grade 1 or grade 2, is less likely to behave aggressively or metastasize than a tumor that's grade 3 or grade 4. Although grading is not perfect, and as I mentioned, with clear cell renal cell carcinoma, sometimes we can see unexpected behavior from it where it shows up in another site even years later after the primary diagnosis. And so grading is not perfect. Actually, the thing that we'll talk about next, staging, is probably a better predictor of how tumors are going to behave than grade. But nonetheless, you'll see grade usually mentioned in your pathology report for renal cancer. This is best validated for clear cell. So how this nuclei look is the best predictor in clear cell. In papillary, we still do it. There's probably some ability to predict the behavior of papillary renal cell carcinoma. But as we get into other other types, it's not clear that the grading is super good at predicting how the tumors are going to behave. And actually in chromophobe, we generally recommend that we don't do the grading, because with chromophobe, as I showed in the pictures earlier, the cells look kind of weird, but actually chromophobe behaves usually in a favorable way. So we found that looking at the nuclei doesn't really help you to predict how chromophobe is going to behave. So the current recommendation is really just not to give a grade for chromophobe, as it could be misleading. And then with some of the other rarer cancer types, it's not clear whether the grade is as important. So this is something that we do to try to predict which tumors are more or less likely to be aggressive, but it's not perfect by itself. The next item that's usually included in the diagnosis lines is the stage. And so this refers to what is the tumor involving? Is it just only in the kidney, which would be the lowest stage, or does it invade any other structures, which would indicate that it's starting to spread away from the kidney and it's starting to become a higher stage? So in this example, I have here the tumor invades renal vein branches, and that would be a stage PT3A. So P stands for pathologic, so based on the pathology specimen, and T stands for tumor. So based on the pathology specimen, the tumor is a stage 3A. And 3A is what has been designated for a tumor that involves renal vein branches, as well as some other structures that we'll show on the next slide. And renal vein branches, it's interesting, we think of cancer, the word cancer comes from the crab. And I guess the way that it's been thought of over the years is that crabs have these claws and they kind of pinch and grab things. And so cancer is known for having this infiltrative growth where the cancer just grows into other structures that are nearby. But interestingly, renal cancer kind of differs from that classic paradigm of infiltrating or invading into things. Renal cancers are often rather spherical, and the way that they invade into blood vessels can be sort of subtle compared to other cancers. And I'll show some pictures of that. But I always think that kidney cancer is sort of interesting in that it doesn't grow in the same way as other cancers we might think of, like, for example, colon cancer, which just kind of directly invades or infiltrates into adjacent structures. Kidney cancer is often very spherical, like a globe, and has more subtle outpouchings where it gets into vascular structures like a vein. So I just thought I would show briefly the staging. In the lower end of the staging spectrum, so again, the lowercase p for based on the pathology specimen, T for tumor. So the tumor is a lower stage 1A or 1B when it's a smaller size and it's totally confined to the kidney. So a lot of it is based on the tumor size up until we start to identify any invasion of structures. So if there are no invasion of any structures, most of it is just based on how big the tumor is. But once we get to the 3A stage, it depends on what kind of structures are invaded by the tumor. And I've highlighted in different colors some of the things that can be invaded, which would get a PT3A stage, or the stage 3A based on the pathology. So if it involves a vein or a vein branch, as I'll show some examples, or the tissue adjacent to the kidney, perinephric means the tissue just outside of the kidney. Renal sinus is sort of the soft tissue that's just inside the kidney, so kind of on the side of the kidney away from the outside, the kind of the fatty soft tissue that's in the middle of the kidney. Or the renal pelvis is where is the collection system where the kidney produces urine and kind of dumps it into the pelvis, which is the collecting system, and it goes down to the bladder. So if the tumor invades any of those things, either vein branches, the tissue outside the kidney, the tissue inside the kidney, or this pelvis, which is the collecting system that collects the urine, if it invades any of those structures, it's considered a T3A stage, that the cancer has involved something other than just the kidney. And then the stages higher than that, T3B or T3C, depend on involving blood vessels, larger blood vessels that are even further outside the kidney. The vena cava is the very large vein that returns all the blood from the body back to the heart. And so occasionally when a tumor involves the renal vein, it can go even further into this large vessel called the vena cava, which brings all the blood back to the heart. So the higher stages are based on whether the tumor involves this large vessel, the vena cava. And then finally, T4, the highest stage, is when the tumor invades sort of all the way through the fat around the kidney to the surface, which is called the Geroda fascia, or if it goes directly into the adrenal gland, which is near the kidney, either of those would be considered that it's sort of invading another adjacent structure, and therefore that would be the highest stage. And so one thing that I just thought I would point out that is important about clear cell renal cancer is that as the tumor size increases, the chance that it invades something goes up dramatically. So that also kind of correlates with what we saw, that the smaller tumor size is a lower stage and the larger tumor size is a higher stage. And I just always like to point out when I'm teaching other pathologists about evaluating these specimens that when the tumor is larger than 4 centimeters, the chance that it invades something goes really high. So when I'm teaching other pathologists about evaluating these specimens, I always say to look very carefully in the larger tumors for the possibility that it's invading something. For the most part, patients are usually not treated with additional therapy just because the tumor is invading something. Usually patients are not treated unless there's evidence that the cancer has spread or metastasized to another organ. But the chance that if a tumor has invaded something, it's a higher risk that may happen, that may develop later. And so I always instruct the pathology trainees or the other pathologists that I work with to look very carefully when the tumor size increases. And you'll notice here that when it's over 7 centimeters, the chance that it's invaded other structures is extremely high. It almost always has invaded something when the size is over 7 centimeters. So this is something that I always try to point out when I'm teaching pathologists about evaluating these specimens, is be very cautious when you're looking at a tumor that's larger. The chance that it invades something is very high. So here's just a figure that I borrowed from a open source from Cancer Research UK, which shows an example of a renal cancer extending into the renal vein. So this blue structure here is the vein that takes the blood back out of the kidney after it's been through the kidney and circulated. The red one is the artery, which brings the blood in. And so for some reason, these renal cancers, especially clear cell, have a tendency that they can grow into veins. And here you can see this round structure is where the tumor kind of started. And you can see this little tail or like a finger that's extending away that's going into the vein, which is a sign that it's invaded the vein and is a higher stage. Actually, in real life, it's usually not so lumpy as you see in this picture, but this is kind of accurate in that you have a circular or spherical mass and then a tail or a finger extending away from it into a vein. So when you see the higher stage, like the T3A stage, that's usually what is happening, is that the tumor has invaded into a blood vessel, or it's invaded into this tan tissue, which is the soft tissue around the center of the kidney. And so here are a couple of histology photographs. This is what we look at as pathologists. We look at microscopic slides, so glass slides under the microscope of these renal cancers. And this white empty space here is a vein or a blood vessel in the sort of middle of the kidney. And here you can see there is sort of a round piece of tumor that is, it looks like it's kind of floating in that empty space. It's not really floating, it's just that we've kind of cut across it, and we're seeing that finger that we were seeing from the previous diagram. We're seeing the finger as if you cut across it. So it's kind of, looks like it's floating in this empty space, but actually it's, we're just seeing kind of like a finger pointing straight down, pointing sort of straight at you. Or just to illustrate that again, this picture is kind of like what we saw in that diagram. The circle is around where the tumor originally was, and then you can see this little finger or this little outpouching that's going away from where the main tumor was and going into a blood vessel. Or in this case, this is another example that I usually point out when I'm teaching pathologists about this, is we have, it looks like we have separate little areas of tumor over here that are with normal kidney in between. And it's probably not that they're really separate. It's not that there are 3 different tumors in this patient. It's that the tumor over on the left has grown into a blood vessel. And because of the way, again, we've cut it, we're seeing just a cross section of that finger. So if you see my finger this way, it looks like it's a straight line, but if you see it this way, it looks like a circle. So we've sort of cut across it, and we're seeing the tumor within these blood vessels. Or here's a higher magnification showing again that cross section, like we're looking at my finger straight down the barrel of my finger. And this white space is the blood vessel, and this little nodule of the tumor is within the blood vessel. And again, this is a clear cell. You can see the cells look very white or very empty under the microscope. So those are some of the key elements of staging of renal cancer, and probably staging is the best predictor of how a tumor is going to behave. I mentioned that grading is not perfect, but staging is probably the best predictor. If it's invading some structures, that's more concerning than just a grade alone. So in pathology reports, you may see some other parameters mentioned. In the next slide, I'll show an example of a synoptic report where, at least in the United States, it's often standardized that you need to report certain elements on every renal cancer. And these are some of the elements that are usually reported. Sarcomatoid refers to when the cancer is kind of losing its evidence of arising from the kidney. So we see this clear cell renal cell carcinoma under the microscope. We know that that is what cancer of the kidney usually looks like, and we could say, oh, as a pathologist, I'm looking at this microscopic slide, and I know this is probably a renal cancer. But with sarcomatoid, the tumor is losing that evidence that it looks like a typical renal cancer and starting to resemble a different type of cancer known as a sarcoma. A sarcoma is a cancer of connective tissue, so sort of a cancer of the bones or the muscle or the fat, rather than an organ like the colon or the kidney or the lung. And so when a cancer progresses from being that of an organ, like say the kidney, to resembling a connective tissue cancer, we call that sarcomatoid. And we consider that sort of evidence that the cancer has lost track of what it's trying to do. It's gotten so far away from being normal kidney that it doesn't even really look like it's arising from the kidney anymore. So all three of these things on this page are considered sort of negative prognostic parameters. Sarcomatoid, that the tumor has started to lose evidence that it's of renal origin, and it looks somewhat unrecognizable as kidney cancer. Rhabdoid, the second one, refers to cells that have kind of a funny pink morphology. So instead of being clear, the cells are very pink. And the name comes from that it looks sort of like a different type of cancer, again, like a different type of connective tissue cancer. And again, we consider that to be equivalent to grade 4. So that's kind of a negative or adverse prognostic parameter when the tumor cells have this rhabdoid pattern that they look like a different type of cancer. They look like a connective tissue cancer. And then finally, necrosis means that the tumor cells are dying. And you might think that's good. You want your tumor to die. And whenever chemotherapy or radiation therapy or other treatments are administered, that's good if the tumor cells die off in response to treatment. But if a tumor cells are dying or undergoing necrosis on their own without any treatment, that kind of indicates that the tumor is growing so fast that the blood supply is not enough to keep it alive. And so the fact that it's growing that fast is, again, a negative or adverse prognostic parameter. The fact that it's growing faster than the blood supply can keep it alive means that it's growing faster than we would like. So here's an example from our institution of what one of these synoptic reports might look like. So I already showed what I would give as sort of the top diagnosis for renal cancer with those 3 or 4 or 5 bullet points. But at least in the United States, most of the time you're going to see one of these summary reports, and most of them are modeled after data from an organization called the College of American Pathologists, or CAP, at least in the United States. And there are certain elements that we have to report for every renal cancer. So if you see a report and it has a bunch of items like this, that's what you're looking at. Basically a list of things that have to be reported for any cancer. And there's a different checklist like this for any type of cancer so that we as pathologists can make sure that we're not forgetting any of the important things that have to be documented. And so here's an example. I think most of the things I sort of talked about: the tumor size, what type of cancer is it, what is the histology, in this case a papillary, what is the grade, it's grade 3, what does it invade, And then again, those 3 items from the last slide, sarcomatoid rhabdoid necrosis, they were not present in this particular specimen. Lymphovascular invasion refers to sort of a microscopic invasion of blood vessels, similar to what we talked about in the last couple of slides. And then the margin status refers to the borders of the specimen. So did the surgeon, was the surgeon able to cut out the entire tumor without any without seeming that the tumor was touching any of those edges, or the margins of where the specimen, the margins of the surgeon cut around the tumor, is the tumor cut touching the surface of those margins anywhere? Usually in renal cancer, the answer is that the margins are negative. It's pretty rare for the margins to be positive in renal cancer. So luckily, usually it's the case that the margins are all negative, but that refers to whether the tumor is touching the outside of the specimen anywhere, which would sort of imply that maybe there could potentially be at least a microscopic amount of tumor cells that are still there somewhere. Lymph nodes are not always removed with a renal cancer. There's pretty good evidence that lymph nodes are unlikely to be involved unless the clinician, the surgeon, can tell that they look abnormal. So often you will see no lymph nodes with a kidney specimen, and that's perfectly fine, perfectly normal, since it's unlikely that they will be involved by the cancer if the surgeon doesn't notice that they look abnormal. So if they don't look enlarged, it's unlikely that they will be involved by cancer. And so it's perfectly reasonable that the surgeon doesn't take any lymph nodes. And then these reports will also have the stage, like we talked about, again, P for pathology, T for tumor, stage 3A. And here in this case, there would be no stage for the lymph nodes since there were none removed, but that correlates pretty well with the clinician's impression. So if they don't think that the lymph nodes are enlarged, usually they're not abnormal. And then sometimes you'll see in your pathology report, if there's any normal kidney or kidney tissue around the tumor, we will try our best to document whether there is any medical problems related to the kidney, for example, diabetes or things like that. And I'll mention that later. But here's an example of a renal cancer with necrosis. So again, these areas have the clear cell pattern where the cells look kind of white because they have the clear cytoplasm. And this big area of pink and purple is necrosis, where the tumor cells are dying, probably because the tumor is growing faster than its blood supply can sustain it, which again, we consider that sort of a negative sign because it's growing rapidly. As I mentioned, we try to evaluate the background kidney tissue for changes of other diseases. So for example, if the patient is diabetic, we may be able to tell that from the background kidney tissue. This is a picture here of the glomerulus, which is the structure in the kidney that filters the blood to produce urine. And when you see these big pink areas in the glomerulus, that's often a sign of diabetes. Other things that we can see more commonly in the normal kidney tissue would be changes of hypertension or high blood pressure. I just like to point out that something that you can always consider as either a person taking care of a patient with kidney cancer or a patient with kidney cancer yourself, one possibility is that you can also have a second pathology review of your specimen. So I think this is something that people don't think of, but the pathologist is a person who looks at the slides under the microscope and makes a diagnosis. And there may be some variation in sort of the level of reporting parameters and details between different practices. For example, if you have your surgery done at a very large hospital, the chances higher that there will be a lot of pathologists at that hospital, and some of them may be specialized in kidney cancer specifically. But at a smaller hospital, there may be only a few pathologists, and those pathologists may have to do a little bit of everything. And so they may not have special expertise in kidney cancer. So it is an option as a patient to request a second opinion on your kidney tumor specimen. Kidney cancer as a field is kind of evolving rapidly, and we're realizing that there are different molecular subtypes of kidney cancer. At present, this is probably not critical, as the treatment doesn't change necessarily that much based on the subtypes of kidney cancer. But in a few circumstances, the treatment or recommendations might vary a little bit based on the subtype. So, for example, in the setting of metastatic renal cancer, the treatment does sometimes vary if it's diagnosed as clear cell or a not clear cell type. That can affect what the choices of chemotherapy might be. And as I mentioned, some of those that we talked about earlier that are associated with syndromes, as pathologists, I think we're getting better and better at recognizing some of these unique histologies. And we can say, hey, wait a minute, this patient has this unusual pattern of their tumor. I think that's highly suspicious that they have the HL-RCC syndrome. And I think that that patient should get genetic counseling. And so that not only the patient, but also their family members can know whether there's a risk that they have this syndrome. Luckily, a second pathology review is usually not very expensive. It's probably on the order of a few $100s, maybe $200 or something like that. And often it's covered by insurance. So this is not a tremendously expensive thing if you're something that you're interested in. On the other hand, molecular testing, if that's something that your oncologist feels would be helpful for choosing a specific type of treatment. Molecular testing sometimes can be more expensive. That can be more in the thousands of dollars, although again, depending on insurance, it may be covered. But usually molecular testing is not something that's absolutely required for diagnosis. It's just something that may be requested if, for example, a medical oncologist treating the patient wants some more ideas about which treatment might be the best or which treatment might be the most likely to be efficacious. But I just always like to mention this, as I think many patients probably don't even realize that there is a person, a pathologist like me, who is receiving your specimen after you have either a biopsy or after you have a surgery. There's somebody like me who receives the specimen, looks at it both with the naked eye and also under the microscope to arrive at a diagnosis. And there's a lot of interpretation here. Is it in the vein or is it not in the vein? Things like that. And so it is possible to request another opinion on your pathology specimen just based on those microscopic slides. And it's kind of a straightforward thing, although the slides are currently, most of the time, they're not digital. So this would involve basically shipping the glass microscope slides via FedEx or UPS or something like that to another hospital. It's generally pretty easy to do. All pathology departments are familiar with this process and do it every day. Patient requests their slides to be sent to another hospital because they're going to be treated there, for example, or even if you just want another pathologist to take a look to verify the diagnosis, it's something that's pretty easily done, just a matter of filling out a form saying that you authorize your slides to be sent to another place. And you can specifically request a certain place, or you can leave it to the pathologist at that institution to decide who they think is an expert in that field. So certainly not something that's required on every single specimen, but just something to be aware of, that it is a possibility. And I think it's something that people don't often know about. So again, I'd be happy to take any questions. I hope that I was able to explain this somewhat well, and thanks again for having me.
Absolutely, Doctor. Thank you for being here. I think we all learned a lot today. We do have a couple questions that came in. Firstly, and I think you may have answered part of this question already, but Deb had asked, can Dr. Williamson please tell us why some people have an unclassified RCC listed on their pathology report?
Yes, so that is sort of a category for a renal cancer that doesn't fit perfectly into a specific box that we have in the current classification scheme. And so I think that probably would be a reasonable time to consider a second opinion. A tumor a tumor might be unclassified just because either because it has mixed features of a few different histologies, or it's just very unusual looking and it's hard to put it into a specific diagnosis. And so I think, not to say that you absolutely have to have a second opinion, but that may be an opportunity if if you could consider getting a second pathology review from an institution that does a lot of work on renal cancer, there could be a chance that this could fit into one of the more recently described or emerging boxes that we're just starting to recognize in renal cancer, and you may be able to get a little bit more tailored diagnosis. So for example, the clear cell papillary that I talked about earlier, if somebody's not familiar with that, since it's more recently recognized, it may actually be quite comforting to know that you have an extremely favorable tumor type. Whereas I think historically, if you see that term unclassified in reports, a lot of clinicians or surgeons might assume that unclassified is aggressive or a bad renal cancer. It's not always the case. There may be some tumors that are kind of borderline, even benign or malignant, which get placed into this unclassified category because they don't fit perfectly into a box. So that's a great question. Unclassified RCC is not a specific diagnosis, but rather a box for a tumor that we can't totally nail it to exactly what category it belongs in. And that would be, I think, reasonable to consider a second opinion in those. It may remain unclassified, but there could be a chance that it would be placed into one of these newer emerging categories that might have some implications, either related to a syndrome or a very favorable behavior or less favorable behavior.
Thank you, Doctor. And Kay Ross asks, how long are pathology slides saved and available for future treatment options?
That's a great question. So again, at least in the United States, I think the College of American Pathologists kind of accredits all pathology laboratories and practices. And so they have some rules for this. And so at least 10 years, the slides have to be saved. And the blocks I didn't get a chance to really explain, but the blocks are the actual pieces of tissue which are processed and placed into a sort of a small brick of wax material, from which additional slides can be prepared for, say, further testing, like molecular testing or other testing, which we call immunohistochemistry. So the slides and the blocks are typically saved for at least 10 years. And in many practices, it's probably longer than that. In many practices, it's almost indefinite, or at least longer than 10 years, maybe more like 20 years. So there is a rule to save them for 10 years, and probably often it's much longer than that. I can see that also there's a question of ischemic type necrosis. Necrosis, like I showed in the earlier picture, is where the tumor cells are growing fast, and you just have what we call geographic necrosis, where you can see kind of the granular debris and outlines where the tumor cells used to be, and that's thought to be a negative prognostic parameter. But ischemic type necrosis is interesting in that sometimes you have more of an area of like fibrosis within the tumor. It doesn't quite fit the perfect definition of regular necrosis. And I think it's not clear that this has the same negative implications as so-called coagulative necrosis, which is what we kind of think of as the bad kind of necrosis. So it's not unusual in a clear cell renal cell carcinoma to have these areas of fibrosis, which some might refer to as ischemic type necrosis. And I don't think there's much evidence or any evidence that that has a negative prognostic prognostic impact. And so that actually may be not very clinically significant. Actually, sometimes I wonder if a tumor that has this tendency to kind of regress or involute maybe is even more favorable if it's the cells are tending to kind of spontaneously go away or become fibrotic instead of continuing to grow. But I don't think that's been very well studied, but at least I can say that ischemic type necrosis does not have the negative implications of coagulative necrosis, which we refer to as the bad kind. So really in your pathology reports, there's no requirement that ischemic necrosis be documented, since it's not necessarily a bad thing. And I see another question is the significance of multifocal tumor. So the one thing that I hinted at earlier is that if you have multiple clear cell type renal cancers, that may be a clue that there's a hereditary syndrome like von Hippel-Lindau disease. Multiple papillary renal cell carcinomas is relatively more common, and that tends to be associated with chronic renal disease or end-stage renal disease. So if a patient has to be on dialysis or have a kidney transplant because their kidneys are no longer functioning, it seems that those patients are more enriched for papillary renal cell carcinomas, and they may have multiple of them. Papillary renal cell carcinoma, there's not necessarily a negative implication of having multiple tumors. But for example, if you've had a partial nephrectomy to remove one, having had a papillary renal cell carcinoma, there is a chance that there could be additional tumors that would develop elsewhere in the kidney. So having multiple tumors may be a risk factor that there may be more tumors either in the same kidney or in the contralateral kidney. That may be a indication to continue to follow the patient carefully for development of more tumors. But it doesn't necessarily have an adverse prognosis. But that also kind of may go back to what I was saying about the second pathology review, though. We have seen cases where you have your main tumor and then tumor within the blood vessels, and the tumor within the blood vessels is interpreted as multifocal tumor or multiple tumors. And I think a lot of the time, especially if we're dealing with a clear cell renal cancer, those are actually outpouchings of the tumor into blood vessels. A colleague of mine and we did a study looking at the staging of renal cancer, and we found that especially for clear cell, it was much more common when you had multiple nodules, that actually the nodules were outpouchings of the same tumor within blood vessels rather than multiple tumors. So if I can simplify that, I guess papillary renal cell carcinoma with multiple tumors, that's not unusual, especially with chronic kidney disease, and it may just indicate that the patient is prone to developing tumors. Clear cell with multiple tumors, that may be a reason to consider a second pathology review to evaluate the possibility that maybe it's not actually multiple tumors, but maybe it's actually tumor within blood vessels, and therefore a higher stage tumor rather than multiple tumors. And I see a follow-up question on the ischemic necrosis, the ischemic changes. Could that indicate an immune response, presence of an immune response? And I think it could. I think we currently don't know why some of these tumors tend to kind of regress or scar or sort of reduce in cellularity on their own. But that's my hypothesis of what's going on, is that there was tumor, and for some reason it's becoming less cellular. The cells are reducing rather than growing unopposed. And I don't think we know exactly why, but the presence of an immune response could be an explanation for that. We've seen occasional specimens where it looks like there probably was a tumor, but it completely went away on its own. And we see just an outline of what looks like it should have been a tumor, but there are no cancer cells left. And we wonder if, in that case, something about the genetics or the biology of the tumor is encouraging it to shrink rather than grow for some reason. And so it very well could be an immune response. There's been a ton of interest in the immunotherapies recently for renal cancer. So like the drugs that enhance the patient's immune response to tumors. And I think we'll be seeing some emerging data soon on what pathologically these tumors look like after they've been treated with immunotherapy. There hasn't been a whole lot of data on that, what happens to the tumor, at least in terms of the microscopic appearance of the tumor after it's been treated with immunotherapy. But I know some institutions that have been doing that, and we're hoping to have some more data published soon on what those look like.
Well, I'd like to thank everyone again for joining us today. And thank you, Deb. I appreciate your input too. I just want to take a quick moment. First off, I know Dr. Williamson's very active on Twitter, so you can follow him there. And I'd like to take a moment to talk about the we have some of the patient support that we have coming up. Tomorrow, Jayla Barnes, she is having a sort of online forum for patients and caregivers to come and talk about any news that you'd like to share, good news about reports that you have or any struggles that you're having. We'd love to just talk and work things out and find support with each other. So you can sign up for that on our website. And next month, we have a regional symposium in Atlanta. If you live in the area, we would love for you to join us. This is going to be a great event with lots of good speakers from a variety of topics covering renal cell carcinoma. And so you can sign up for this on our website as well. And then finally, if you have any suggestions for upcoming kidney cancer conversations, please don't hesitate to reach out to me or anyone on the staff at Judy Nicholson Foundation. You can reach us at thejudynicholsonfoundation@gmail.com. Thank you, everyone. And thank you, especially Dr. Williamson. If you missed any part of this recording, it'll be posted on our website on Monday. Thank you, everybody. And
Thank you.
y'all have a great day.